Okay, good morning. I'd like to first start by thanking SAGES for the opportunity to be here this morning, and also thank our chairs of this session. It's a genuine pleasure to be here with you. So the work I'd like to talk about today, as mentioned, is regarding vital signs following laparoscopic bowel resection and their value in detecting an anastomotic leak. Okay, great. So regarding anastomotic leak, just to start with a little background, many would consider this, aside from mortality, the most severe complication of this operation. It's difficult to always diagnose a leak, as the classic symptomatology is a peritonitic abdomen, hemodynamic instability, but it's much common to just have failure to thrive or failure to progress. This variation in clinical symptomatology is represented by the broad prevalence rates, ranging from 1% to 35%, depending on the study analyzed. For the purposes of this talk, though, we're going to look at clinically significant leaks, which are more on the order of 3 to 6% in occurrence. And within this group, mortality ranges from 10 to 15%. Now, a meta-analysis in the early 2000s by Bruce et al. Analyzed 97 different studies assessing leak, and in those papers there were 56 different definitions of what constituted an anastomotic leak. Now, all of these definitions included both clinical and radiographic findings, but there was no consensus that could be generalized to our patients at large. Now, our group has previously looked at vital signs in relation to anastomotic leak, and the motivation for that study really came out of peer review in our morbidity and mortality conferences, where we would present a case where a patient unfortunately developed a leak, and as we went through the hospital course, people would point out tachycardia on postoperative day 2, leukocytosis postoperative day 3, and suggest that the diagnosis was just missed. What we found in the open colectomy group specifically was that vital sign abnormalities are ubiquitous and are not predictive. So our motivation was looking at laparoscopic surgery, which is less invasive and causes less deviation from the body's baseline physiology, assessing the utility of vital signs and detecting leak in this group specifically. So it's always important to maintain a high clinical suspicion for anastomotic leak, but there are some factors, both patient-specific and operative-specific, that increase risk. In regards to patients, malnutrition and steroid use certainly increase risk, as well as tobacco abuse and cardiovascular disease, which typically lead to atherosclerotic buildup and poor blood supply. In regards to the operation itself, prolonged operative time, distal anastomosis low in the pelvis, poor blood supply following bowel resection, and causation of septic conditions also increase risk. So the real goal of our study, again, as stated, was to evaluate and profile vital sign aberrations following laparoscopic bowel resection, utilizing the American College of Chest Physicians criteria for what constitutes an abnormal vital sign. That said, we then wanted to assess the utility of these clinical markers in detecting anastomotic leak in our laparoscopic bowel resection group. And we hypothesized, again, that based on the decreased deviations from baseline physiology that laparoscopic surgery induces, an abnormal vital sign would be much more significant and reflective of an impending anastomotic leak. So our study design was a retrospective case series of a prospectively maintained complication database over a 5-year study period from 2009 to 2014. And this all occurred at the University of Vermont Medical Center, which is in Burlington, Vermont, and affiliated with the University of Vermont College of Medicine. Now, the significance of our study period is July 2009 is whenever we first implemented an electronic medical record. This record was important because it basically gave us the power to assess a large data set. As I mentioned also, definitions are very important in this topic. So for our institutional definition, an anastomotic leak was defined as a finding at reoperation, an extravasation of contrast on an imaging study, a postoperative abscess in direct proximity to the anastomosis or a postoperative EC fistula. For outcome measures, we looked specifically at the presence or absence of an anastomotic leak, and then also looked at average vital signs, temperature, heart rate, respiratory rate, blood pressure, and laboratory values, specifically white blood cell count. And in total, we had over 175,000 data points to analyze. During our 5-year study period, a total of 1,059 patients underwent bowel resection, 282 of which were performed laparoscopically. And as you can see in our laparoscopic group, there were 20 leaks in total for a leak rate of 7.1% in total. So between these two groups, this is what we'll assess in the following graphs. So this graph is looking at temperature max by postoperative day. Each crosshatch represents an individual patient's maximum value on each postoperative day. By taking the averages of these patients' Tmax, we're able to generate a group mean, and this is represented by the bold, heavy lines, red referring to leak and black referring to no leak. What you can see is by postoperative day 1, you're starting to see a deviation. By postoperative day 2, there's an approximate 1 degree difference between the leak group and the no leak group. Now, while this wouldn't characterize itself as a fever, it's still a significant difference that we could pick up clinically between these two groups. In regards to heart rate, the same trend holds. By postoperative day 1, the groups begin to diverge. By postoperative day 2, there's an approximate 15 beat per minute difference, and by postoperative day 3, more on the order of a 25 beat per minute difference. Respiratory rate, looking at the same thing, where there's an approximate 4 degree respiration per minute difference. Looking at minimum systolic blood pressure, where you have an approximate 10 millimeters of mercury difference on postoperative day 2. And then lastly, looking at white blood cell count, where early on in the postoperative period, we find no difference, but later on in the course, where you would assume most people who had uncomplicated courses have gone home, you do start to see divergence around postoperative day 5, 6, and 7 in regards to white blood cell count. So for our conclusions, what we essentially said was postoperative day 2 is critical because in today's era of enhanced recovery protocols and rapid recovery pathways, we're more and more often looking at postoperative day 2 as a decision day. Can a patient go home? So based upon our reports, looking at temperature, heart rate, respiratory rate, and blood pressure, there are in fact significant differences between leak and no leak groups. Now, while they may not classify under SIRS criteria as abnormal, they're still significantly different and can be utilized to assist us in decision making. Thank you very much.